Hello,
Hi there.
how are you?
Good, good, good. Thank you for having me. Good to be here.
Good, so good to see you. Thank you so much for joining us. This feels like a bit of a long time coming. I'm just so glad that we're here today and that we have so many questions for you. Thank you in advance for all of your time and insights,
My,
answering all of them.
my pleasure.
Um, and so, as I mentioned earlier, but for those who are just joining us now, Dr. Lavy is the founder and medical director of New England Fertility, which has been in business for 30 years. And it's actually one of the first to specialize in third-party reproduction. So in fact, the egg donation program has been around for 29 of those 30 years, I believe, and surrogacy since the mid-90s. So you've really been helping build families for more than 3 decades now, families from around the world. So among many other quite impressive accomplishments in Dr. Lavy's past, you completed your residency at Yale University School of Medicine. And fun fact that you might not know, but I was actually born there. I did the math, and I do believe that we may have crossed paths on a labor and delivery floor one fine day many years ago. I won't say exactly how many years ago, but can chat about it after. And so Dr. Lavy was also an assistant professor at the Division of Reproductive Endocrinology at Yale, as well as the director of the Yale Program for Assisted Reproduction. So, that said, fast forward to today, we're just so lucky to have you here to answer so many of the questions, the most common questions that you've received over the years, as well as the most common ones that you're kind of receiving now today during this current COVID climate, and the ones that we've, received once we announced that you were joining us. We received so many through our social media followers and, from intended parents who are using GoStork to find their providers, emailed us. So I'm just really excited to ask you everything. And we can't wait to get to all of that. But again, thanks to everyone joining us now. If you didn't get to ask questions in advance, but you would like to, feel free to do so in the comments, and we'll do our best to get to all of them. And, we know this time isn't perfect for every single person, but we know that so many of you watch these after on IGTV or in our blog recaps or other locations. So if you're joining later, thank you, and feel free to send us your feedback. And finally, for those new to us at GoStork, we are the first fertility marketplace where intended parents find, compare, and connect with top fertility providers. Our mission is to provide inclusive, trusted access to affordable fertility care. And that's all over at GoStork. But for these lives, we would just love to help bring more transparency and access to helpful information and support for new intended parents and fertility patients. And again, that's why we're so grateful to have you here today. And, with that, without further ado, I would love to stop talking and let you do most of the talking from here on out and, just dive right in. We have so many questions in a limited time. So I'd love to start with, one of the most common questions currently. If you'd like, I'll just go ahead.
Sure, please.
Perfect. So as one could guess, not hard to guess that some of the most common questions are related to COVID. And so we knew we were going to cover this regardless, but then received, questions from our followers about it. And one of the first is just simply, do you require patients are vaccinated prior to receiving your services?
So, yeah, the answer to that is no. I'm a big believer in the vaccine. I think that, in my opinion, there's very few exceptions, everyone should get the vaccine. And this is particularly true for women who are planning to become pregnant or women who are already pregnant. I think all the authorities, CDC, FDA, ACOG, everyone basically is on the same page with that. However, I think that, I would sort of stop there and say, well, I think it's a good idea, but, we know that not all people are comfortable with the vaccine. And, because we are basically a egg donation and surrogacy clinic, that's really all that we do. These questions are a little bit more pointed because, it's one thing if you're coming in to become pregnant yourself and you decide that you don't want to be vaccinated, that's sort of maybe your issue. But when you're a surrogate and working for an intended parent couple, I mean, you have an added responsibility. But even with that, I still think that it's not something that I can mandate. I can encourage, I can try to convince them, the surrogates, but I will not mandate it because interestingly, and I do find it a little bit surprising, but we do have actually a good number of intended parents who are actually fine with it. Either themselves are not vaccinated or that feel that they can live with that.
Mm-hmm.
And the reality is, I mean, the reason actually that there is such a big push for the vaccine is because especially with the Delta variant, there have been a number of cases where pregnant women actually have it worse than someone who's not pregnant. For whatever reason, it may have something to do with the immune system in pregnancy. So in theory, at least, and a pregnant woman has a higher risk of becoming sick with COVID, not just getting COVID, but actually ending up in the hospital, in the ICU, and so forth. Now, interestingly, the COVID virus doesn't really cross the placenta, doesn't cross to the baby. So it does not infect the baby, but it can affect the pregnancy by, if a woman is sort of really, really gravely ill, it definitely increases the risk of preterm deliveries and so forth. So that's the reason that people recommend the vaccination. Now, the reality is that so we've been actually working through this COVID nightmare for 2 years now,
Mm-hmm.
and at the beginning, we closed down because we didn't really know what to make of all of it, and we didn't really know how to handle it. But very quickly, it's probably around May of 2020, we opened up again. And this was way before the vaccine. And we were basically working through it with surrogates and with egg donors. And, thankfully, thank God, knock on wood, we really never had anyone with COVID, actually. And certainly no one that got really sick. So, we got sort of our experience, which was actually not so bad with working through COVID.
Mm-hmm.
And now I think even though women are not all willing to get vaccinated, now that the vaccine is widely available, and there is that aspect of the herd immunity that protects people that are not vaccinated. So I think, even though again I recommend it, I think it's a good idea. I think if you take a woman who is about to become pregnant and she doesn't get vaccinated, I think the risk that you take of her being seriously ill or having an issue is really not very high. So I think there is a way, you can make that argument very well.
And I just wanted to thank you again. Several weeks ago, we published an article that you wrote for us, actually related to vaccine hesitancy in the surrogacy community, but really it was much more of a fact-based analysis. It was just very insightful around specifically how safe it is to get vaccinated when pregnant and the risks involved with not getting vaccinated. So for anyone who didn't catch that article, it's in our link in bio. It's very informative by Dr. Lavy on our blog. So check that out.
And I'd like just to add one small thing, because now, now we're dealing with the booster.
Mm-hmm.
So now we thought we had it all under control, and now people ask, well, I'm planning to be pregnant. Should I get the booster? And that's not 100% resolved, even though, again, some of the authorities are recommending it. There's really not that much in the way of studies about the booster in pregnancy, but in theory, it shouldn't be any different. So again, I recommend it. I think someone who's planning to be pregnant and is eligible to get the booster should get it.
And if they already are pregnant as well.
Especially yes. If they're already pregnant, for sure, yes.
Great. And so how have you been coordinating international journeys, particularly during this COVID time, with travel restrictions? For example, if a sperm source, egg donor, or gestational carrier is overseas from the intended parent, I think it's really put some difficulties in place, but been able to work through it.
Well, so I think, I think when we're going to look back at this COVID pandemic, I think it's going to change basically a lot of different things. A lot of the way we work, the way we think, the way, we function. So for us, it was an adjustment. I think it was in a way sort of a way to actually assess the processes that we do and figure out if we could do it differently. So for example, we work a lot with international couples, South America, Europe, Israel. So before COVID, if there was a male partner and he needed to give a sperm sample, we would basically ask them to come here.
Mm-hmm.
And mostly would come, it was really not a problem. And then from one day to the next, basically there was a travel ban and we couldn't do it anymore.
Mm-hmm.
So we sort of very quickly adjusted, and we've identified a number of clinics in different countries, in South America, in Europe, in Israel, that would actually were happy to collaborate with us and allow men to go there and freeze their sperm, do some blood work, do whatever we need in order to be able to use that sample.
Mm-hmm.
And of course, we vetted them, we compared the protocols. We actually organized a courier company that specializes in transport, FDA testing, all these things that are required. But now, actually, I don't know that we're ever going to go back, because now that travel is available, actually, people still prefer to do it locally because it's so much easier.
Mm-hmm.
So we've actually worked through that with no issues at all. The parents actually went through the surrogacy process without actually ever coming to the US until the baby was born.
Mm-hmm.
And at the height of the pandemic, it was actually some of them who were not able to get in even though after the baby was born. I think that's now changed and sort of back to normal, more or less. But again, it gave us a different perspective on how we can do it. And I always prefer to meet people in person. I always like for them to come in. But it's up to them. If it's easier for them, it's more convenient, less expensive, we try to accommodate.
Mm-hmm. And there were obviously, accommodations in place in so many cases. Intended parents are in different states than their gestational carrier, depending on just who's available, or maybe if there's more surrogacy-friendly laws in different states. So they're already joining appointments through FaceTime and other methods, right? But it just seems like so many other things, there's some permanent changes coming out of COVID, and maybe they will add more convenience to our life and help us reassess how much travel is really needed.
Right. But, I think, and again, this is for another time, but, so for example, I do all my consultations now on Zoom.
Mm-hmm.
I think it's a great tool. I think, allows you to see the other person, allows you actually to share information, documents, whatever.
Mm-hmm.
But it's definitely, and it's convenient, of course, but it's definitely not the same as meeting people in person. And especially if you're dealing with such a highly emotional, difficult process,
Mm-hmm.
I think, I still prefer, after we do our first meeting, in some way or another to get, especially if they're in the US, to get them to come to the clinic, just to meet in person, see the office, meet the team, just to get sort of a little bit more comfortable.
Yeah, I agree. So another question that came in related to international intended parents, and I will just say, if it looks like I'm reading, bear with me. I am, because there's so much content and so many questions came in. I want to be true to what people specifically wrote to us. So,
Sure.
So do you provide medical documentation in order to cross the border to come for treatment at your clinic?
Yes. So, it depends on where they come from and whether they need a visa. That's actually also has been extremely, extremely difficult because the U.S. consulates in actually most countries are not really making it easy for people who are looking for a visa. So yes, we have. I mean, we have letters that we write for explaining what the process is about and the fact that it's time sensitive and it's urgent, and sometimes it works and sometimes it doesn't work. It really depends on who's there at the window at the consulate on that day.
Well, I'm sure people appreciate your help, at least, and support along that part of the journey. And so on to more general topics. Let's start at the beginning of the journey, as we were just talking about consultations. How does a new intended parent come well prepared for their first consultation and appointment with you?
Well, I think it's, again, it's a lot of it is about expectation. And it depends on who they are and what kind of baggage they bring with them.
Mm-hmm.
So people come from different places. So just as an example, we work with actually more than 50%, more than 60% of our clients are same-sex men.
Mm-hmm.
So they come usually with no baggage. right? I mean, they know from the start that this is how they're supposed to have their family. And in some ways, it's a little bit easier
Mm-hmm.
emotionally because they come in with positive, and then you have the couples, the heterosexual couples who have been through multiple IVF failures, and basically egg donation, surrogacy, or some combination is sort of the last resort. So for those people, of course, it's there's a lot that they bring with them, and they need a different approach, different support in the process. I think the first consult really is more about just educating the clients, the patients, about what we do exactly. And I found that again, one of the COVID benefits is I had to put together all these PowerPoint presentations for the specific things that we do. And I'm a great believer in educating the patients and making sure they fully understand even the details of the process. And I always worry that they get intimidated by too many moving parts or too much detail. But I think it's really important that they understand. So I think it's really the first contact is more about trying to learn who they are, what they need, and then showing them, basically how it works. And in most cases, I think they're very relieved because the process really is not really that difficult. It's not that complicated, I should say. And a lot of the small technical things that need to happen, they don't need to worry about because
Or maybe it's not as complicated once they found you and they're in your office and they found the right provider to work with. I think getting there can be pretty hard too. But
well, yes, and and it's like anything else. Once if there's something you do well and do a lot, it looks easy, right? And like this morning, we had no hot water, and I looked at the whole thing and and the guy came in and he just flipped the switch. He said, "Here, this is why."
Yeah.
So it's really more about finding someone you can trust, and someone that you feel comfortable with, and let them do what they do. And and for me, it's really, really important to get to know the couple, the individuals, where they come from, their background, because everyone comes from a different place. Everybody needs something a little bit different.
And I believe you have like an onboarding questionnaire to also help with that process and, help them.
Of course. So,
Yeah.
especially if you have a history, if you've done treatments before, I mean, to your question, the more information you can bring with you and actually send me ahead of time, the easier it is for me.
And go ahead, sorry.
No, go ahead.
And for those just beginning their process, particularly if their infertility is unexplained, what questions do you ask? And what should they expect to be asked about when they're new to the clinic? And related to that, what tests might they potentially need to take soon after?
Well, so, unexplained infertility is, we can talk about it for an hour, but it's one of those things that I think is most difficult to handle because, these are couples that basically healthy, no problems, trying to get pregnant, nothing works. They do all the testing and still not pregnant. So it's very, very frustrating from this patient perspective. And it's also difficult from the practitioner's perspective because, I mean, how do you know what to do if you don't know what the problem is, right? So I've developed a very systematic approach to basically trying to get all the information that I need in a very short period of time. So we call it an evaluation cycle. We take the woman's cycle and do a bunch of tests at different points in the cycle, check her hormones, check her ovulation, the tubes, the uterus, check the sperm. And that way, by the end of that cycle, so within 1 month, we can sit down and I can basically review everything, tell them what I think is going on, what we're up against. And for people who with infertility in general, and especially with unexplained infertility, I think the most important thing is to have a plan, to have a treatment plan. So I think it's very, they're relieved with the fact that they know what they're up against and what they'll do this month and next month and what happens if it doesn't work. I think that takes a lot of the pressure and the stress off.
Mm-hmm. And so another one that came into us, what is the standard, routine protocol for new patients at the clinic, whether it's hormone stimulation, Clomid, IUI, IVF, like how many attempts at each stage do you do before moving to the next? Obviously this would vary based on unique cases, but is there some general answer that you could give us insight on for this?
So, actually the last slide that I have in the PowerPoint for the evaluation is basically to say, okay, we gather all the information and we figure out what's going on, and then we can discuss the options. So, depending on what you find, you may need ovulation treatment, you may need IVF right away. But if you find nothing wrong, then you basically try to see where the couple stands, right? How anxious they are. Some people say, we just want to do IVF. We don't care, we just want to get pregnant now. Other people are willing to go through the normal, basically, steps if they're not in such a big rush, and especially if, of course, insurance is a big factor in all of this. Mm-hmm. They go through basically IUI for usually 2 or 3 months, no more than that, because if it doesn't work, it doesn't work. Mm-hmm. And then if it doesn't work, go to IVF. And sometimes, it's interesting that, we do the workup and we have all these tests that tell us about the possible factors, the possible reasons. And we know that the tests are not complete, because still with all the testing, even though they're getting better and more accurate, there's still about 20% of couples who have infertility and have all the testing done, and still everything's normal, but that there's something wrong. So you basically just want to make sure that you've covered everything, and then you have to see what the couple is comfortable with as far as the treatment plan. So the couple really is a very important part in designing the plan.
Got it. So for the person who submitted that, partially up to you.
Right.
And so a follow-up to that from the same person, since some of these procedures are so time sensitive, do you work 7 days a week to accommodate the woman's cycle?
Well, that's a decision that I had to make 30 years ago. So yes. Yes, and the answer is yes.
And how exactly do you modify protocols for advanced maternal age?
Maternal age.
Advanced maternal age.
Yes. Mm-hmm. Well, so, that's, of course, still the biggest question of all, because as much as we've advanced in our ability to treat people with infertility, that's sort of one obstacle that we still don't have a solution for. And the problem is actually simple. The problem is that women, in contrast to men, only have a limited egg supply. So women are born with all their eggs, and then at some point a woman runs out and then goes into menopause, usually around the age of 50. Men are different in that they continue to make sperm forever. So it doesn't really matter how old you are. Mm-hmm. Fertility for men actually goes down only a little bit with age. But women actually, once a woman gets into her 40s, it becomes increasingly more difficult to get pregnant. So for about 10 years before menopause, it becomes really difficult to get pregnant. It takes longer, higher risk of miscarriage, higher risk of birth defects. And it's interesting that when you look at just history, so we know that actually the age of the first period keeps actually going down, right? So if you compare records mm-hmm. from 200 years ago, women would get their first period at around age 16. Today, it's not unusual that women get their periods like 8, 9, 10 years old. So that we know has changed. But interestingly, if you look at these records, and there are some places that have kept records, the age of menopause has not changed.
Okay.
Even though lifestyle is better and lifespan is better, health is better, the age of menopause has not changed. So that's still the biggest challenge. And what we are trying, actually, there's different things that we're trying that are a little bit sort of new and exciting. Don't really have any sort of a proven benefit yet. Trying to get around this problem. So one thing that I would say that, for is of course not to wait, right? If you're in your 30s and you have an opportunity, just take it. Don't wait. Unfortunately, the way our society is and our culture is, and people basically delay having children. So it's not unusual for couples to come in and the woman is in her early 40s and now they're ready, right? Everything is set and now they're ready to have children, but it's a little bit late. So one thing is, if you're already in 40 years old and you're basically now you're ready, you don't have much time to waste. So you need to go to the doctor. You need to get your evaluation right away. And when you have a choice of treatment, you need to be maybe a little bit more aggressive than you would be if you were, 5 years younger. So that means usually going to IVF right away. But even with IVF, we have a problem because those women usually don't respond well to the drugs. The quality of the eggs are not as good. So that's what we're actually focusing our attention. And we have some very interesting sort of results. So I just briefly will mention a few things that we do. So one is that we modify the stimulation protocol because, you have somebody who's in their 30s, it almost doesn't matter what you give them. Their egg production is good, the egg quality is good. But for women who are older with reduced ovarian function, it does matter. And actually what we've learned that, using less drugs is better because, the tendency is to get your ovaries are sluggish, will sort of give you a whole bunch of medication and hopefully it works. It doesn't work.
But over medicating could,
Had a bad effect on the eggs,
right.
yes. And then using different combination, we use sometimes growth hormone and some cocktail of different drugs, but in a very low dose. So that seems to work well. And that's not that new and not that different. But what we've learned, for example, is that there is the possibility of using, it's called PRP, platelet-rich plasma, which is basically an extract of your own blood that contains some growth factors. So there's some actually very promising studies that show that when you can actually take that and inject it into the ovary, and that increases activity and egg production, egg quality. So we tried that. We've been trying this now for a good number of months, and we've had some mixed results, but some that were surprisingly good.
Wow.
Another thing that we do that, again, is different is, when someone does IVF, they do the IVF, we take the eggs, and then we basically wait for them to get another period or 2 periods before we try it again. It turns out that actually if you take the eggs and immediately start another cycle, not wait for the period, actually sometimes you get better results on the second run.
Sorry, we have a new person joining.
Yeah, well,
I was going to say, I love is that a portrait of your dog?
That's my dog, yes.
Oh.
His name is Tyson, and he's a Beagle Dachshund mix.
Wow. This is Lucy, a Lab Rhodesian Ridgeback mix. She's like 80 pounds.
She's very serious.
Yeah. She loves kids.
Yes. So anyway, so this is again an area that's always been a problem because we didn't really have good solutions for. Of course, again, if it really is too late, then egg donation is a good solution. But for many people, it's not a trivial switch from using their own eggs to using donor eggs. And for some people, it's worth trying something that maybe not completely proven, but is really not harmful and may have a chance.
Wow, thank you. That is so much interesting information. I actually didn't know about the thresholds changing as far as early on in that fertility journey, not journey, but that the periods are starting earlier, but that menopause has not been changing over the centuries. It's all really interesting. And so actually the next topic up, and I want to be respectful of time, but the next topic up is egg freezing. And, you know, again, this is something we had planned to cover and then received many questions about it. So we prioritized, you know, our followers, and we'll cover everything. But regarding freezing technology, we wanted to talk about the durable life of frozen eggs. And, you know, with technology improving over, you know, the several years significantly, that enables longer term success rates, right? So can you walk us through that as well as the vitrification process?
Right. So basically, egg freezing now, I mean, it's come a really long way. So maybe I would start with that, you know, right now I can tell you with confidence that the viability, the success with frozen eggs is essentially the same as it is with fresh eggs.
Mm-hmm.
So that it took a very long time to be able to make this statement, but the technology, the egg freezing technology has improved. And it basically allows us to do that now. And the thing, we've been freezing cells forever, you know, like sperm for 100 years, embryos for like 30 or 40 years. But egg cells were always a challenge. The egg cell actually is the most difficult cell to freeze. Mostly because, you know, the difficulty in freezing the cell is proportional to how much fluid, how much water is in that cell. So the more water there is, the more difficult it is, because when you freeze, you're creating ice, and the ice can damage the cell. So, for example, the sperm, which is actually the smallest cell in the body, has no water content at all, and there's millions of them. It's very easy to freeze, because even if all of them don't make it, you still have plenty. And they're not really that susceptible to the damage. So it doesn't really matter what technology you use, the sperm usually survives. With the eggs, is very, very different. And, you know, the older methods, which we called slow freezing, where you lower the temperature very gradually, thinking that it will be more protective, were not working. I mean, we tried it for a while. I think we had our first baby in Connecticut from a slow freeze egg, but it was rare that people actually were able to get pregnant. So it wasn't until the vitrification, which it's sort of a little bit ironic, because it's really the very simple method, came along that we're able to freeze the eggs effectively. And the vitrification is basically what's called flash freezing. So you lower the temperature very, very quickly, from room temperature to liquid nitrogen temperature in like an instant. And because it happens so quickly, there's no chance for ice to form, and there's no basically risk to damaging the egg. So now we are actually using egg freezing in different ways. For example, we use it for women. I mean, actually started with women who are about to lose their ovarian function for, you know, surgery or, you know, cancer treatment, chemotherapy. So just before that happens, we can take the eggs and we can freeze them. That's were the first candidates. And then once that became possible, we're using it for different other things. For example, we are using it with egg donors, allowing us to freeze eggs and create egg banks, which is sort of the equivalent of sperm banks.
Mm-hmm.
And then, of course, the more recent that sort of gets the news is what we call social freezing, right? A woman is, you know, 35 and single, and basically worried that by the time she's ready, she'll be too old. And that's doable, and it's not really that difficult. And again, I mean, the fact is that, you know, if you freeze the eggs now and you come back in 5 years or 6 years and you want to use those eggs, they're going to be exactly the same as they were today.
Mm-hmm.
So that's something that, you know, people actually do. Again, I mean, it's sort of a two-edged sword, because it gives women that sort of, in a way, false sense of security, right? I have my eggs frozen, I don't have to worry. But you know, again, for the right person, it's a good option.
Mm-hmm.
And we do actually quite a bit of that. And, you know, typically, and again, it's a topic for another whole talk, but you do the IVF and you stop after the egg retrieval. Once the eggs are harvested, we freeze them right away. And then when you're ready to use them, you basically just thaw the eggs and complete the IVF process.
I think that's a good segue into egg donation. And again, had a list of questions submitted to us for this as well. The first time actually reading directly from someone that submitted a few days ago, mostly related to the number of eggs retrieved and those expectations. So how many mature eggs do most people receive from egg donors? And how many of those mature eggs fertilize normally? And, you know, again, infer that they're asking for kind of averages, but we know that this can vary.
Right. No, I definitely can tell you the average. So what we expect, and again, it's not by accident, because when we screen the egg donors, when they're accepted to the program, they go through very rigorous testing. And the first thing we do before we worry about anything else is just checking their, what we call the ovarian reserve, ovarian function, how many eggs they have. Mm-hmm. And we, of course, take women that have above average ovarian reserve. So intentionally, because they not only have to be healthy, and they not only have to have good eggs, but they also have to have the ability to produce multiple eggs in response to the treatment. And that's not, there are three different things entirely. So for example, we have egg donors that have no trouble getting pregnant, they have kids, and they come in and we give them the drugs, they don't really respond. Mm-hmm. So they're fine to get pregnant for themselves, but they're not a good egg donor. Mm-hmm. So we have all these tools to screen those out and pick women who we know will do well. And doing well means that they'll produce somewhere about 20 eggs. Again, you have to be really careful, and my big concern is because you're dealing with young, healthy women who don't usually have children, who probably will at some point want to have a family. You want to be very careful to do it very safely for them. Mm-hmm. So, you know, if you take a donor and you give her more meds, she probably can make 30, 40, 50 eggs, but we try very hard not to do that.
Got it.
So a typical donor retrieval yields about 20 mature eggs, 18, 20 mature eggs. And now when we get the eggs and you know, we of course want to know, so it's not really about how many eggs or how many mature eggs, it's how likely it is to end up in a pregnancy, mm-hmm. How many of those eggs. So we basically create the embryos, we fertilize the eggs, and then we do two things to be able to choose to identify those embryos that are the best of the best. So one thing is we grow the embryos in the lab for almost a week to what's called the blastocyst stage. And that basically right away, it's a very simple way to identify the better embryos because some of them just don't grow or stop growing. And even with egg donors, you know, highly selected, still we end up with probably 30, 40% of the eggs that don't develop all the way to the final stage of blastocyst. Mm-hmm. And then we take those blastocysts, those good embryos, and put them through genetic testing. It's called PGS, where we actually check the chromosomes. And again, surprisingly, you still find that about 30 or 40% of those are abnormal. All right. So you actually start with 20 and then end up usually with about 4, 5, 6 genetically normal embryos. Mm-hmm. So that's always a little bit of a shock, right? To people coming in and say, well, I got 20 eggs and I only Absolutely. Have five embryos. But keep in mind that each one of those embryos has been through all this testing, and each one of these embryos has about close to 80% chance of creating a baby. So, you know, it depends on how many children, and we always talk about that in our first visit, was what are your plans? You know, how many children you're thinking, you're hoping to have, and that will basically tell you, you know, how many right. embryos you need.
One of the questions someone followed up with was, will one round of egg retrieval normally be enough for 3 children? Or will the donor need 2 rounds? And then also, does the donor receive the same fee for the second retrieval?
Well, so as far as how many kids you can have with one retrieval, again, it depends exactly on the donor. But as I said, on an average, if you have 4 to 6 genetically normal embryos, that's almost always enough to have 2 children. Mm-hmm. and if you're lucky, maybe a third. So that kind of an assessment we usually do after the donor's retrieval is done and after we have the embryos analyzed. And then we say, well, we have 4 embryos, and you wanted to have 5 kids, it's probably not enough.
Mm-hmm.
And then the donor can come back. Most of the donors will come back, especially if it's for the same recipient. Do they get paid more? It depends. I mean, we basically, my philosophy on paying the donors is we pay them basically for their effort and not for their eggs. So,
Right.
but I know that's sort of not exactly the way it's done around the country.
Yeah.
So we generally pay them the same or maybe a little bit more if they ask. But really, I think a lot of it has to do with the donors. And, there's so much information out there. So the donors have their own sort of communities and they come and say, well, I had a good retrieval. I want more money.
Mm-hmm.
And so then I leave it up to the parents to decide if they're okay with that.
Yeah, and I think one thing intended parents don't necessarily realize if they're brand new to this and just considering egg donation is how much you can understand about your egg donor in advance. So just for example, GoStork has over 10,000 egg donors in our database. It's just very diverse, the largest free online database of egg donors. And you can compare, egg donors that are first-time donors. They might cost a little bit less, but you won't understand their prior history because they don't have any. But you can see for donors that do have, prior history of egg donation and proven fertility, you can understand how many eggs were retrieved in prior cycles, and it can just help be an indicator. So that can be part of your criteria in selecting your egg donor, in addition to all the other factors you might be interested in, like their medical history and their education and their appearance and everything else that people look for. So you really can, know a lot about a donor before you decide to move forwards. And so another one from that was submitted, do you recommend coenzyme Q10 for egg donors? It's for those not aware, this is just a vitamin to enhance fertility.
Well, so the CoQ10 actually it's an antioxidant.
Okay.
And it's given as a supplement. Personally, I think it's great. I think everyone should take it, whether they're a donor or recipient or just anybody.
Mm-hmm.
Just because, a lot of the environmental effects that we see on fertility and on the body in general have to do with what's called free oxygen radicals. So these are molecules that actually are very destructive. I'm a big fan. I recommend it. We give it to men before they give their sperm, and we give it to women before their IVF. And we encourage as well donors as well to take it because I think it's an easy thing to do. Really doesn't have any side effects, no downside.
Great.
So, yes.
Another good takeaway. A final question we had, but I actually noticed there's a question, I think, about egg donation that was submitted a few minutes ago here, which I'll check. But so when the scenario comes to you, which is my sister, my cousin, my friend wants to be our egg donor, what's your perspective on this, your point of view? What do you advise? Like, check AMH levels regardless, but like, what are the key criteria and considerations that you kind of advise them on from there?
Well, I think potentially can be a beautiful thing. Right? I mean, especially if it's a family member, a friend, and people feel more comfortable because they know the genetics, they know the background. Of course, you have to be careful because, in contrast to an anonymous donor, that person will always be there. And if you have a baby, they're always going to be there. And you want to make sure that, they understand, the ramification of being a directed donor.
Mm-hmm.
So, we spend maybe a little bit more time on the psychological counseling for directed donors than we do with just anonymous donors. So the other thing is, the criteria. So, we have for our own donors, very strict criteria, age criteria, AMH criteria. And of course, if somebody has a sister who is maybe 34, we only take donors up to 30. Maybe her AMH is 1.1 and not 2 or above. That is what our criteria. We do the same screening that we do for anybody else. And then we sit down and say, listen, maybe, we probably wouldn't take her as an anonymous donor, but if it's important to you and if she's up to it, then why not try it?
Mm-hmm.
And so I think, the criteria that we use for our egg donors are very, very strict. I mean, you can be 32 or 33 or 35 and still have great eggs. But we've decided, arbitrarily, I would say, to not take anybody over the age of 30. But if you have a donor and you really are motivated to use her, and again, it's something that we definitely deviate from our standard protocol for that.
And we often hear to seek legal counsel regardless. You would do a contract with an egg donor if they were not in your family, but you just want to make sure everyone's aware of the future considerations and
Yes.
everything involved. So I'm just going to read this question from Harrisol79. I'm currently in the process of choosing an egg donor and wanted to know, should I be taking into consideration my antigen found during my blood work and picking an egg donor? Does that make sense?
Yeah, I mean, of course. I mean, if there's anything specific to your case that may affect the pregnancy and the baby, you want to make sure the donor is. So, for example, if you have a blood type, some kind of antibody, an Rh factor, so you want to make sure the donor will not create a problem for you.
Mm-hmm.
So we have our standard workup, and then we adjust it to the individual case. Yes, so absolutely, you should pay attention to that.
Okay. So thank you for all of that. And the next topic is embryo testing, which again, we of course both plan to talk about and received a handful of questions on. And so just starting with the basics, in embryo testing, what is included and what's like nice to have.
So embryo testing is basically it's with these things, there's always, people that are for and people that are against. I'm for embryo testing.
Mm-hmm.
I think it helps increase the success. It lowers the risk of miscarriage. So basically, what that means is that you take, as I mentioned before, we take the embryos, we grow them all the way out
Mm-hmm.
to the very final stage that they can grow outside of the body, and then we do the genetic testing. So the genetic testing, first of all, it comes under different names. We used to call it PGS, and we call it now PGTA. But what it is basically is you take a few cells from the embryo and do a genetic analysis, which essentially, in most cases, is just a chromosome analysis. Right? So the first question is the safety. Because, and it turns out that doing it on a blastocyst, 200-cell embryo, taking 3 or 4 cells is safe. It does not hurt the embryo. And then you take those cells and you put them through a genetic test, which is basically, like I said, checking the chromosomes. And that gives you a genetic profile for each embryo. The testing actually is the chromosome number, so we can identify things like Down syndrome, extra chromosome, missing chromosomes, and so forth. But it's actually a much more sophisticated technology that allows us also to identify smaller issues, breaks in the chromosomes, what's called deletions with missing a little piece of the chromosome, duplication, inversions, all these things that are more subtle, but can definitely affect the outcome and affect the health of the baby. So again, some people are not big fans of it. I think that anyone that goes through IVF, including women over the age of 40, including women under the age of 30, should have it done because it would allow you basically to maximize your chances of success.
Mm. I think you kind of covered some of the follow-up questions that we were asked, which is, do you recommend testing for egg donors under 30? And what are the risks of testing? Do you know all the risks? I think you kind of covered that, unless you have anything to add.
Well, I mean, do we know the risk? I mean, it's like anything else. I mean, we don't know for sure all the risks, but I can tell you, we've went from doing the genetic testing on the 3rd day of the embryo development. And very quickly, we realized that it's not good for the embryos and it's not helpful for success. But doing the genetic testing on a day 5 embryo blastocyst is a whole different story.
Mm-hmm.
Because when the embryo is a blastocyst, basically it's already what's called differentiated, where you can actually tell which part of the embryo will become the baby and which part of the embryo will become the placenta. And then you can target the area that will be the placenta, and that way not hurt the baby. At that point, the embryo has about 200 cells, and you're only removing 3 or 4 cells. So that's the theory, but the reality is that it's been, this type of genetic testing has been going on for a good number of years now, and consistently the studies show that when you pick embryo based on genetic testing, you get better results. So again, I mean, it doesn't make the eggs any better. It doesn't make the embryos any better,
Mm-hmm.
but it allows you to identify the good embryos. And there's different arguments that people make. Like, why would you do it on a donor? I mean, these are healthy
Mm-hmm.
women, carefully picked. The reason is because 30 or 40% of their embryos are abnormal.
Mm-hmm.
Would you do it for someone who's 42 and only has 2 embryos? Well, unless you want to put back an abnormal embryo, yeah, I think it's a good thing to do.
Mm-hmm.
So I'm in one camp, and I'm sure I know that there are other people that are not so much in favor, but I am a big believer in that.
Thank you for sharing that. And another big one. Oh my gosh, she never makes any noise.
What?
Of course, today she is.
She wants
Another big one. What if intended parents want twins? So what do you advise as far as the risks involved to oneself, as well as if they want in the case of surrogacy? How do you advise? I know some clinics are really starting to not want to do twins with gestational carriers. And so kind of where's your stance on that?
So I think, first of all, I think there's a big difference between women who are doing their own IVF that have never been pregnant and gestational surrogacy. I think for someone who's never been pregnant doing IVF, I think they should not have twins. I think it definitely increases the rate, makes the pregnancy a high risk, and there's a significant risk of premature delivery and all the complications that go with that. And mostly because these women have never been pregnant, we don't really have any track record. With surrogacy is different because we of course pick surrogates. I mean, the number one criteria for surrogacy is that they have children. I think you should hold her. The number one criteria is that they have children, and then allows you to sort of look a little bit more closely at their pregnancies and any complication, how they deliver, when they delivered. So within that group of surrogates, you can identify surrogates who are better candidates to carry twins. Still, they would have a higher risk than carrying one, but not very much. So I always say, if you want to have twins, then you have to find a surrogate who's willing to carry twins and who we think is able to carry twins. Same with COVID, I don't really say no. I just say, let's talk and let's figure out, what is the right thing for you. And if that's really what you want, then I think, I think it's okay if you find the right surrogate.
And another one that's, actually moving on to a couple of medical diagnoses related to the fertility journey, and one that it's important any time of year. We've been having conversations about this more, especially recently with October being Breast Cancer Awareness Month. We've been really diving into this topic, but how do you advise patients who come to you having a cancer diagnosis, but who hope to, build a family in the future, just as far as their potential timing and next steps? Assuming this means that they want to do fertility preservation as one of their next steps before starting treatment.
So, of course, I mean, there's not one answer to this question, but it really depends on the case, on the patient, their age, their cancer. So for that, I always work with their oncologist. Because, some cancers are more hormone sensitive, some cancers are more estrogen sensitive. But the simple answer is that you can adjust the medication, the treatment, to basically get around this problem. So even someone who has, for example, a history of breast cancer and is treated and gets clearance from her doctor, we always say, okay, well, let's try to come up with a IVF protocol for preservation that will minimize the estrogen rise, and you can do that. And of course, ideally you do it before they get treated, but often that's difficult because it all happens sort of one day to the next, and there's a big rush, and so it's sometimes really difficult to do before treatment starts. But again, that's something that we always work with the oncologist and say, well, do we have a couple weeks so we can maybe quickly do an egg retrieval if it's not going to affect the outcome of the cancer. So this is a case that you really, really have to know the individual patient and their situation and work as a team with the oncologist.
Mm-hmm. And I want to make sure I say this correctly for someone who submitted it, but how do you make a woman feel safe and cared for during the oncofertility journey? Just so that she has her emotional needs met and closure after this fertility step, because then she's going to move on to, or is currently on, that uphill battle of chemo, radiation, surgery, etc., to hopefully save her life and be a mother in the future. So, how, I'm sure you have a lot of experience with this. How do you support?
Well, I mean, it's very, very tough. It's very, very tough. And, because as I said, these are sort of the famous, like, Friday afternoon phone call that I have somebody in my office who just diagnosed with cancer, and what do we do? And, when the diagnosis is first made, I mean, there's a lot going on, a lot of emotions, a lot of drama, a lot of things to consider, that basically life-saving things to consider. So fertility sort of gets pushed down the line as far as priorities. But again, I think it's something that if you, I think it's a team effort. And for both, doing the right thing medically and as well as the emotional support. And I think the emotional support in any part, for anyone who does fertility treatment, is somewhat, neglected, I would say, but especially in these cases, because there's so much else going on that, you need to be able to sort of balance all these things and get the best result for the cancer, but at the same time, see what you can preserve for fertility.
And so moving on to another topic related, but to a different medical diagnosis, we wanted to talk a little bit about HIV positive, circumstances. So for those who hope to build a family, I know this is, important. For example, not all men know they can pursue surrogacy safely if they're HIV positive, and would just love your thoughts on this, including, how gestational care can work with intended father who, again, is HIV positive.
So, I think that actually that's sort of been an amazing breakthrough for treatment. I just spoke this week to this gay couple who one of them is HIV positive, and he said, listen, I never ever imagined I can have kids.
Mm-hmm.
So having that option is, I think it's an amazing thing.
Agreed.
Now the thing is, of course, we want to make sure that we do it safely, and we've had cases over the years that there is basically a heterosexual couple that one is positive and one is not, and of course that's sort of different, right? Because they know what they're in, and they basically take a chance or can take a risk if they wanted to. But when you're working with surrogates, it's very different, because basically these are healthy women, and you want to make sure that nothing bad happens to them. So we work with quite a few HIV positive men. Fortunately, we actually collaborate with there's a group in the Boston area called SPAR, a Special Program for Assisted Reproduction. It's actually run by one of the pioneers, Dr. Ann Kiesling, who is one of the pioneers in actually research on HIV and sperm. So she actually has this program which basically allows you to basically confirm that the sperm is not, there's no virus in the sperm. Because, and so they have certain criteria. You have to be basically undetectable levels under treatment. But one of her discoveries actually that if you take these men who are basically undetectable, treated, so there's basically no virus in their blood, that's what it means. And if you take their sperm and you do repeated analyses, every once in a while, one of their samples will have the virus. So that's the basis of what they do. And they basically bring the men there and they take a few samples and they basically check and confirm that the sample is HIV free. And again, it's a team effort, and Dr. Kieslings usually will talk to the surrogate and explain exactly what that means and reassure the surrogate that basically that there's really no risk of getting HIV from the embryo. So, it's, again, you need to have all these people involved, but at the end, it makes it very possible for HIV positive men to have children.
Just like having children, truly it takes a village, but it's such an incredible development. So,
Yes.
Thank you for sharing that background. And so finally, a question we ask everyone, but just what is your advice or what words of wisdom or hope would you like to pass on to those just kind of researching and beginning their journey? Sometimes we hear personal mantras or quotes, but it could come more from your medical background as well. What would you leave people with?
Oh my God. So, well, I think the message really is that I think if you have to recognize that, the technological advancements have been incredible. And I've been in the field for a good number of years, and I'm still amazed at what we can do now that we're not able to do before. Which means that for me, as far as just being here to help people have children, is the fact that we can help more and more people have children. Of course, it may not be what you had originally imagined, that how you would have your family. But if you're willing to take advantage of all these different options, including egg donation, including surrogacy, then, that's pretty much everyone can have a child, almost. Not 100%, but so I think, the message should be one, of optimism, right? But you have to sort of, also keep an open mind and accept the fact that it may not happen exactly the way you were planning it to happen, for it to happen.
Yeah, you have to accept the change in plans, but I think GoStork was built on optimism as well. And I think it's so amazing that you can be amazed in your work, after still be amazed consistently after all these years. So I think that's incredible. So thank you again, for all of these thoughts, everything you've shared today, everything you do every day, to help parents and help people start their families. And for those of you who didn't get to think of questions after this or didn't get to submit your questions, you can feel free to DM either of us after this. If you have other topics that you'd like to submit for these lives and you'd like us to cover, feel free to always write to me. I think we discovered the cause of the dog situation. There were friends in the backyard that she wanted to play with, and we solved that. So apologies for that slight interruption. And, thank you again so much for your time and all of these insights. And this will be live soon. This will be recapped on our blog and on our YouTube. And with that, hope you all have a great rest of your day and hope to see you back here again soon.
Yeah, thank you. Thank you for having me. And, it's sort of just a quick pitch for GoStork, because I'm, familiar with all of you, and I know that all of your hearts are in the right place for doing this. So, and I think it's an amazing service, both for education and helping people basically find what they're looking for egg donors, surrogates, clinics. So yeah, I really appreciate what you guys do.
Thank you so much. Yeah, I think everyone's heart's in the right place when you're in this industry trying to help people, and I really appreciate you saying that. Well, have a great rest of your day, and I'm sure you have a busy, packed afternoon. So, we'll talk to you soon.
Bye bye.
Thank
Take care.
you. Bye, everyone.
Bye.
Thank you for joining.